The relapse criteria, like we talked about earlier, this is probably the biggest grey, I think, within what patients believe is a relapse, what their neurologists believe is a relapse, and what the committee considering the applications consider a relapse. There can be a lot of difficulty in this area. Basically, it has to be confirmed by a neurologist, but that doesn't mean you have to see your neurologist at the time of a relapse. So if you have a relapse event, don't be worried that your neurologist didn't see you. I mean, it is ideal if your neurologist can see you at the time of a relapse, but if you go and see your GP and they examine you and they talk on the phone, it's confirmed that it's a relapse, that is okay. The other thing is that you would do is ring the MS nurses. They would document what your symptoms were, and all the neurologist has to do is read exactly what it was, and then that can be confirmed by a neurologist as a relapse. What my suggestion to you would be is to write, as well as doing both of those things, is to write exactly what you're experiencing. Because sometimes what's recorded by the nurses and the GP and what's needed, there can be a little bit of a discrepancy. Whereas if you've actually written it all down, it's amazing how the detail is that you guys record is usually much greater. And sometimes it's there's like one word difference. And it's that one word that makes all the difference in terms of reaching the criteria. So my advice to you would be, yep, call the MS nurses, yes, see your GP, but also just diary whatever your neurological symptoms. Diary how long they go for, diary what symptoms you have, diary what drugs you take, diary whether you went to hospital or not. That can be phenomenally helpful. So yeah, not necessarily have to be seen by the neurologist, but must be satisfied that clinical features were characteristic and met the criteria. They have to be a new symptom sign or sustained worsening of previously experienced symptoms. So this is where it gets a bit murky in terms of, is a relapse event a new attack on the nervous system of the immune system, or was it that this person's previous damage became more obvious to them and to their doctors? As it stands, with the way these treatments work, you're more likely to expose yourself to harm from therapy if you're not having active immune-mediated disease. So even though it seems unfair, if you see your doctor and they say, I think that was old activity, I don't think it was a relapse, the reason they're saying that is because they don't want to expose you to the risk of the side effects of the drug when they don't think it was the immune system causing the problem. And I think that is difficult. It can be very hard to tease the two out, and sometimes MRI scanning can help with that. It has to last at least 1 week, and so that's why when you diary it is very important. So as soon as you notice a new symptom come on, document the date, document what the symptom was, document how long it lasts for. And the other time we've run into problems is this 1 month business. So a patient with newly diagnosed MS who's having a lot of events might have one event, and then before the month is over they start having another one, but that doesn't count as 2 separate relapses, and so they won't meet criteria. So that is really disadvantaging that person, unfortunately, but it's written in black and white, so we just can't argue with it, unfortunately.
Sorry, can I just interrupt for a second? Do me a favour, would you mind just stepping back?
You can't see through me? These are all on the Pharmac. This is just directly copied from the Pharmac website. So yeah, this isn't my typing. This is all written there.
So it's not your creation?
Fortunately not. I wouldn't want to claim it as mine. And then be severe enough to change either the EDSS or one part of the functional system score by 1 point. So that's the EDSS score, you've seen the sort of 0 to 10 grade, but with that 0 to 10 is made up of functional systems. So one is what's called brainstem, so that's all the cranial nerves. The other is pyramidal, which is the motor, like your power and reflexes. The other is bowel and bladder, so urinary symptoms or bowel symptoms. And there's, I don't actually know how many there are, but there's functional system scores, and the neurologist has to make sure that your symptom meets all of this, as well as changes your functional system score by 1 point. And that's where I'm talking about diarying your symptoms, because sometimes sometimes if patients are remembering things, they might forget to say, yeah, actually my hand was clumsy and weak. People will just say to me, oh, my hand, it didn't feel right and it was tingly. It lasted for about a week and then it got better again. And that won't meet criteria. Whereas if they look in their diary and say, oh yeah, it was tingling and it was numb, then they probably will meet criteria. So it can be as much as a single word that makes a difference. And clumsiness as well is important, and weakness is important, but it's really just documenting everything. It has to be distinguishable from fatigue, and it has to be not associated with a fever. They're made by the neurologist or general physician, initiated, supervised by a neurologist. These ones aren't really... Yeah, these ones actually aren't really, they're not really important in terms of diagnostic criteria. They're more things for neurologists to make sure that they look after you in terms of your JCV, negative or positive. And we can't prescribe the drugs with Copaxone or beta interferon, but we don't want to do that anyway. So hold off. Any questions about the treatments we'll come to. The last little bit that I'm going to say is about relapses. Oh, we're doing quite well for time, Therese. So I found this. I was looking for a picture. I was Googling a picture to talk around on a relapse. So I just found this randomly. I don't even know where it comes from, but it said recognise, record, report, review. And I think that's the hardest thing, I think, for patients in terms of relapse, is trying to tease out what on earth. When am I having a relapse? What is a relapse? And especially in the first year, when people are newly diagnosed with MS, their brain is just so hyper-vigilant around what's happening in their body that it's very hard to tease out what a relapse event is. And so I think diarying can be helpful, but at the same time you need to live your life. So it's looking for new neurological symptoms. And they need to be new. I probably need to be new, although in saying that, if you've had MS for a long time, it needs to be a significant worsening of your current symptoms. And recording it and reporting it to the MS nurses and the GP, and then reviewing what's happening out of that, seeing your neurologist, talking about whether you meet criteria for treatment. This traffic light is for GPs to help educate them about what might be a relapse. So we're working on, this one I think was designed down in Christchurch, and this is our sort of modified version of it to send to GPs. The MS nurses are currently working on a really good flashcard that I think Fiona's going to liaise with you about getting it out to the general people, and it's just not quite available. It's going to the printers, but it's a really good, helpful flashcard to help you. It's along the same lines of this, and it sort of tells you things. It talks about the intermittent symptoms, which are just come and go and are probably background, and then something that comes on, persists, is new. That could be an MS relapse, and it also has when to call your neurologist, when to call your MS nurse, when to see your GP, and when to come straight to hospital. So that card will be really helpful for you in sort of identifying all of that.